Great. Hi, everyone. Thank you for being quick. I'm not going to spend time introducing the panelists now. Their bios are also available online. I will very briefly introduce them as they speak. The idea of this session is very quickly for each of them to run through what they do. They're either clinical or they work in a program that helps people with diabetes. And really what I wanted to get out of this was for people to see that, it's not just one small little group of people improving their diabetes. This is really, it's global, it's worldwide. There are various ways of doing this, there are various people doing this, and the outcomes are incredible and really inspirational. So the idea is they'll each do a very short presentation. I will play bad cop and stop you. I've sent them lots of emails about practicing their 6 minutes. So once they're done, we'll then hopefully have a little bit more time for discussion and questions from the audience. So I'm going to start off, and the reason they're sitting in this, because we have all the presentations ready. David Unwin is a very famous GP from the UK who has done a whole lot on low carb and helping people with diabetes go into remission. And David, you're up. You can sit down or you can come up and stand up to you.
Stand up. Thank you. There we are. Hello. So I'm here to bring you some real world hope and good news from primary care in the UK. So that's by our team. We've been offering a low-carb approach to our patients with type 2 diabetes for 10 years now, and it has revolutionized our practice. We're having such a great time. I want you to take away a really simple message. Type 2 diabetes, just eat nutrient-dense foods that don't put your blood sugar up. I believe it's nearly as simple as that. I want you to meet a patient. That's Dan. He's 40 years old. At that point, his blood sugars are sky high. He's got a hemoglobin A1C of 95 millimoles per mole. That's so high. He's also, of course, got high blood pressure and fatty liver. In our practice, we've had a 9-fold increase in people like Dan. This is an epidemic, a pandemic. It's all over the world. But clinicians, we can do something. We decided not to wait until the guidelines or somebody told us what to do. We rolled up our sleeves and got on with it, starting in 2013. So you can see there, Dan has got his blood sugars, his hemoglobin A1C has been normal for several years now. It's possible. And look, there he is now, okay? And we've done this 133 times. So if you're a clinician and you've never seen drug-free remission of diabetes, please try, have a go. Just eat food that doesn't put up your blood sugar, nutrient-dense food. It makes all the difference. I want you to look at what we've achieved over the years. So in March 2017, we only had 15 cases of remission. At that point, we had 130. For those people who choose a low-carbohydrate approach at Norwood Avenue, in 2017, 31% would achieve remission. We are learning things. Clinicians, we learn things. We learn from mistakes. If you go low-carb at Norwood Avenue now, you have a 50% chance of achieving remission. That is astonishing. And not just that, but we've got 20% of the entire diabetic register in remission. And this is in 10-minute appointments in the British underfunded health service. It's possible. It's possible. We know now, just research from last week, the ones who get remission, on average, are consuming 77 grams of carbohydrate a day. So just for your interest, that's what they're consuming. I always want to keep things really simple. A high blood sugar, see it as an interesting puzzle with your patients. Don't see it as a problem. Patients shouldn't be problems. They should be an interesting puzzle that we solve together. Nearly always, a high blood sugar is something you ate. Nearly always. Sometimes it's stress and other things. Nearly always it's something you ate. So with a patient, find out what did they eat. Where does the sugar come from in your diet? And so often it's actually starch. And I, for many years, forgot about starch altogether. Starch is soon to be sugar. Eat things that don't put your blood sugar up. This is somebody with type 2 diabetes wearing a Freestyle Libre. So they have a normal blood sugar. They eat a single banana, and that blood sugar goes way up. So eat foods that don't put up your blood sugar. So if you have diabetes, a banana isn't a great food. The same person with type 2 diabetes had a large plate of chicken butter curry with roasted sprouts. Nothing happened to the blood sugar, nothing at all. That's the basis of the low-carb diet. Eat tasty food that doesn't put up your blood sugar. This approach can pay for itself. So this is nationally collected data. Every GP is checked on in England, and that's our practice on there. So we spend the least of all the GPs in the area. We're saving nearly £70,000 per year on drugs for diabetes alone. If every GP in England prescribed as we do, they would save £270 million per year. We could build a hospital per year on this alone. I'm often told, well, you know, if you go low carb, you probably increase the fat. What's going to happen to cardiovascular risk? Maybe they're all going to die. They don't. So these are measures of cardiovascular risk. Serum cholesterol improves significantly. HDL increases. The cholesterol ratio improves. The triglyceride improves by 40%. This is published data from Norwood Avenue. Blood pressure improves. So really, those are all the cardiovascular risks I can think of apart from age and smoking, and they're all improving at Norwood Avenue. And this is work we've published. It was published in BMJ Nutrition. This subject is so interesting to the world. There is such a lot of fascination with this, that paper is the most popular paper that BMJ Nutrition have ever published. That is how important this is in the world, that people want to know more. I'm coming to the end. This is Dave, and there he is on his 60th birthday. You can see the balloons behind him. Dave, 60, very high, look at that hemoglobin A1C, 108 or 12%. Weight, waist, blood pressure, of course, was up. But look at him only 16 weeks later. This is why I love this approach. Look at him. It's amazing. He came in to give me a massive hug. All his family came in. We're all celebrating. Medicine can be great fun. This is what it's about, making a difference. And it gives hope. Cases like that give hope. The more of them there are in my practice, the more people sign up. I'll have a go now. So we're finding a greater and greater proportion of our patients want to try this approach because they all know somebody who looks like that now. That's what we could do in society. Our work has been transformed into an NHS-approved app. Only months ago, the Freshwell app, it's free. Any of you can download that. 60,000 people have downloaded it so far. You're going to hear about the low-carb program that I helped design. Well, at least 460,000 people have done that. It really rolls out. The final thing is the interest of insurance companies. This really gives me hope. So not only am I working with Swiss Re, but I'm working with Level 2 in North America. And they have shown that if only people will engage with a low-carb approach, they can have cheaper health insurance. Amazing. We're getting some friends in high places. Thank you so much. Thank you.
So Wim is somebody that I have known for a while. He's based in the Netherlands, and he's got an amazing story to tell.
Yeah, my name is Wim Tilburgs. I'm the founder of a non-profit foundation called Lifestyle for Health. I'm also the last year's winner of the best diabetes idea in the Netherlands from the Diabetes Fund. And we won this also for type 1 and for type 2 diabetes. And also we won the public award. I'm also on some governmental boards in Holland. Really, lifestyle is really living up. I have a personal story. This is me in 2015. I reversed my diabetes myself through research on internet. And my inspirers were Robert Lustig, Gary Taubes, and Peter Attia. I done it on a ketogenic diet. I lost 25 kilos in 4 months, 20 centimeters of waist gone, and 52 millimeters of HbA1c went down. My wife did it with me. She lost also 20 kilos. So I had a lot of medication. Not only all the, I was on 200 units of insulin in 2015, 200 units, but also on Dipakine, on Zoloft. Not only, I had a lot of medication, really a lot. I couldn't walk 500 meters anymore when I was 55. Where is it? Last year, I ran 6 half marathons on my 63rd birthday. So that's lifestyle. So that made me to start a group of people. I just wanted to help other people. I say, if I can help one to get the same result, I will be a happy person. So I have now a group of 2,300 people. We help each other online, and we do teaching, and we have every Saturday, we give their waist circumstance, they give their weight. So I have now data for 226 people, and they all lose 6 kilos in average, 7 centimeters of waist, and average is 11 centimeters of millimole going down with the HbA1c. And this is all free just in an online community and on our website we give a lot of webinars with doctors. We have good support of our doctors, but it's all patient driven, patients helping each other, support group, no doctors, no dietitians, people helping each other, no cost, for free, no money. This is one of our people, Lisette, also. She did 80 kilometers walk, also losing 20 kilos, and each of those people is a person. It's a new life, it's a new family. Every person counts. Here you see a lady, 75 years old, with colon cancer. She would not even get into a lifestyle program because she's too old and too many complications. Here she's welcome. She has a new life. She is feeling happy again. She's walking with her grandchildren. And this is what we see is happening. So we see people losing about 10 kilos in the first 10 months, and then we stabilize them. And very different, we have this data over 4 years. We have 4 years follow-up, and it's very difficult. Losing weight is easy, keeping weight off. It's not a diet, it's a lifestyle. So we see the same with waist circumstance. Sorry. But it's more. We have now 11,000 people in our groups because we have a group for Alzheimer's, we have groups for bipolar disorders, we have groups for type 1 diabetes, type 2, epilepsy, inflammatory bowel disease, longevity, migraine, acquired brain injury, obesitas, psoriasis, rheumatoid. It's much more than just diabetes. Lifestyle is 60% of the people who come to the GP is lifestyle related. But we go further. We go into, because we know in the poor neighborhoods in the Netherlands, people live 7 years shorter than people in a richer neighborhood. they have 25 more years of ill health. So we go into the neighborhoods, we go to the church, we go to the mosques, and we help each other with support groups. And also, we give them freestyle levers. We install the freestyle levers for them so that they know what they eat, what is happening. When they go walking after dinner, they see the drop in glucose. They can see it themselves, so it's educating them. It's called the Sugar House. In a lot of communities we are starting this up now. And the most important, and my next, and that will be this afternoon, I was a veteran. I was in Lebanon, and I had PTSD, and I got all the symptoms of bipolar disorder, and I was one of the first in the Bazooki podcast to reverse bipolar disorder, and it's insulin resistance in the brain. It's very important. So we were the first to translate Dr. Palmer's book in Dutch. It's the first translation, and we will make really sure that it's not only body, it's here, Alzheimer, bipolar. So that's what we are doing. Thank you.
With Wim, it's a little bit like one of those infomercials. But wait, and there's more, and there's more. Amazing. So Allison Hull is a board-certified adult and pediatric physician from Florida. Please go ahead.
Hello, thank you so much. So let's start with my why. My why started about 8 years ago in clinical practice, and I was following the dogma that Nina talked about the low cholesterol, low fat dogma, and I just saw patient after patient who was so sick with metabolic disease. So I said, I have to do something different. So my first introduction was to the Diabetes Solution by Dr. Bernstein. Has anyone here read that? Yes, so that was published in 1997, and he himself was a physician with type 1 diabetes. And he talked about how he reversed so much of his hyperglycemia through carbohydrate restriction. And so that was my first play with my patients was, okay, we have to make a change with your nutrition. But what I found in my clinical practice was, talking to them in my office was not enough. They would go home into their home environments and the wheels would fall off. So I needed to create a program that would extend care into their home, create accountability, education, and support. So I launched my program and my protocol about 7 years ago. But then I realized there's one more piece of disconnect I must fill, and that is the science of behavior change. So I found an ideal diet, and I was teaching them how to incrementally make changes to do so, but it wasn't founded enough in the science of behavior change. So that was the third part of my journey, and I'm happy to report that I've had over 3,000 patients go through the protocol thus far, have tremendous outcomes, which you're gonna hear about. And then in March of this year, I merged missions with a company, Readout Inc. And collectively, we are taking the protocol, implementing it into an application format that will integrate into electronic health records with interoperability to be an extension of care, not just for my patients, but the masses. So I want to talk a little bit about this protocol. It's a 4-month protocol, and it's evidence-based in the behavior modification utilizing nutrition as a metabolic therapy. It's extremely thoughtful, intentional. It's a multidisciplinary approach with incremental change. And the aim for this protocol is to be prescriptive based on diagnosis, readiness for change, personal motivators, and health literacy. It is not a one-size-fits-all program in that respect. And I'm gonna walk through some of the details of the 4-month protocol to help you understand kind of the layout and why it's been proven to be so effective. It all starts with the self-discovery stage, which is finding a purpose. We help our patients find a purpose and identity that they connect with, so their behavior and their decisions follow suit. The educational component, I cannot highlight how empowering education is for our patients. I don't care about their age, their demographic, their educational level. People are empowered by education, and we start by teaching them the science of carbohydrate modification, the science of habit formation, and everybody is checking glucose, whether you're diabetic, pre-diabetic, or none of the above, because it's such a reward mechanism, feedback mechanism moving forward. The nutritional changes are incremental. At the end of the first month, they're eating at least 3 servings of healthy vegetables a day, 3 servings of fats, and we've lowered their carbohydrate intake to 100 net grams per day. I'm gonna move quickly for time. Month 2, this is when we start focusing on building grit, creating somatic awareness, where people are utilizing extrinsic reward mechanisms to bridge the gap to, I just feel better doing so, so I'm gonna keep going. The education shifts to mitochondrial health, and we start teaching the science of fat oxidation, as Ben already alluded to help them understand how to prescribe their carbohydrates more customizable to them. At this period, the end of month 2, we've increased non-starchy vegetables to 6 to 8 servings per day, increased those fat sources, protein sources are dependent upon sex, height, ideal body weight, and the carbohydrate threshold is dependent upon the outcomes in measuring fat oxidation through the Biosense Breath ketone analyzer. This is a methodology to help patients understand, are they in a state of fat oxidation? And if so, we've met our carbohydrate threshold. If we're not in a state of fat oxidation, the program is customized for them to make adjustments accordingly. And then in month 3, we're harnessing self-compassion. We teach them the skill set of self-compassion to create stress resiliency, and that's a piece of the puzzle that I found to be so effective in maintaining long-term success. The education here is now shifting. We're talking about autophagy. We're talking about time-restricted feeding as another tool in the tool belt. And we're also talking about exercise and increasing that in their tool belt as well. The action plan pretty much continues forward with the nutrition. Once again, we're utilizing the Biosense device to identify, are we in a state of fat oxidation? We're continuing to monitor glucose levels as well as a feedback and self-reward mechanism. And then month 4 of the protocol, the self-discovery shifts to teaching the patient leadership. What I have found in my 7+ years of doing this, when we put a patient in a position of leadership, that's how they persevere with long-term success. They do this through accountability and relationships. Relationships are a key driver, my friends, for long-term success. The education here now turns to sleep, and we also teach them how to identify their carbohydrate thresholds long-term. For the sake of time, I'm moving fast. All right, action plan here. At the end of the 4 months, we're gonna be teaching them, showing them their outcomes, not just biometric outcomes, but also outcomes on depression, anxiety, and sleep, because we want patients to understand that they're moving so many metrics in life far beyond the scale. Our outcomes are such. In the last 5 years of doing this protocol, we've seen an average weight loss of 8% body weight, and that has been sustained for greater than 2.2 years. We see an average reduction in A1C of 17%, triglycerides of 30%, and reduction in blood pressure of 8%. The second line here is a randomized clinical control trial that I did in conjunction with USF and Levels Health, and in our protocol, we saw 54% of patients have complete resolution of fatty liver disease. We saw improvements in depression, anxiety, and sleep. Okay, to personalize this, I want to talk about Dave quickly. Dave is a 77-year-old male, and he really takes this leadership and drives forward with it. We have a Facebook community, and he every day is posting about his long-term success. He did the program over 4 years ago. He lost 80 pounds, reversed his diabetes and his fatty liver disease from stage 3 to stage 0. We have Catherine here. She was sent to me by a fellow colleague in my organization, a gastroenterologist. She was fighting for her fatty liver disease with the typical low-fat, low-cholesterol mechanism, and it was not being effective. So she came to me, she did our protocol. You can see she lost 41 pounds, reversed her fatty liver disease, and had significant improvements in those triglycerides. And her walk away was, I have the skill set and the confidence to not just do this today, but every day moving forward. And she has sustained that success for 2.5 years. My last case study involves James and his son. I am the physician for the entire family. And James' story is so beautiful because he didn't just change his life. He changed the entire life of his family, including his son here, who his son also had fatty liver disease, now reversed, also lost 25 pounds. And you can see James himself lost 76 pounds. He had significant improvements in his lipid levels. HDL increased from 38 to 71. And his biggest takeaway is, I can actually be a positive role model for my family moving forward. And I will end on this. My well-being company that I originated 7 years ago, our vision was this: ignite the purpose of one to transform the well-being of many. All of us here are the one to transform the well-being of many. Thank you.
Thank you, Allison. So Adam Wolfberg is the Chief Medical Officer of Virta Health. He flew in this morning, I think from Chicago. So thank you very much for being here and look forward to hearing from you.
Thanks so much. Delighted to be with all of you today. I'm the CMO at Verta, and I thought I would just tell you a little bit about how Verta works and some of the data that we've seen from the research evaluating the program. So our purpose, and it really is a remarkable sort of guidepost for all of our employees, is to reverse diabetes in 100 million people. And we're not going to make it by 2025, but we will get there eventually. As you all know, diabetes is an enormously important epidemic in the United States and around the world, and has significant cost implications for our health system and our economy. And that's sort of the background in which Verta operates as a commercial organization. There's sort of two pillars for what Verta does. Our focus is on carbohydrate restriction. And so patients who sign up for Verta, usually through their employer or through their health plan, are introduced to a carbohydrate-restricted diet. The second piece of it is that they interact with Verta. We have a team of employed health coaches and a team of employed physicians and nurse practitioners who manage their medications when they come onto the Verta program, quickly deprescribing their diabetes medications. And it's this sort of two-pronged approach, the nutritional therapy and then the really daily interaction with their health coach and with their healthcare provider that allows for the outcomes that patients see on our program. I'll tell you a little bit about the patient experience. So a patient is introduced to Verta and they begin nutritional changes. And we have sort of three categories of patients, but the program is relatively similar. We think of our patients either diabetic, pre-diabetic, or simply our obesity population. And they're introduced to nutritional changes relatively early in the program once they qualify for Verta. They meet their health coach and interact with that health coach sometimes several times a day. The coach is helping them guide their nutrition and sort of understand the Verta program and learn the Verta program. As they enter the carbohydrate-restricted diet, they're quickly reducing their diabetic medications, often cutting their insulin dose in half, and then frequently getting off of insulin and other medications altogether. The way we operate, like I said, is in the context of either a self-insured employer providing this as a benefit to employees, or through health plans that provide it as part of the health program. And these are just some examples of the clients that we work with. So as to outcome, the thing about Verta is that we are extraordinarily evidence-based in the way we think about the program and think about explaining our results and our outcomes to both our patients and our clients. The program originated from a trial that was conducted at Indiana University starting in 2015, and we've published data for 1- and 2-year outcomes and presented data at the American Diabetes Association of our 5-year outcomes. We continue to evaluate the impact of the Verta program on our patients in a variety of different conditions. The results we see are as follows. 54% of our patients at 2 years had diabetes reversal and reduced their insulin dose by 81% on average. Across the spectrum, we, like I said, reverse diabetes in 54%. Pre-diabetes progression to diabetes is reduced considerably compared to usual care. For our obesity population, the weight loss is quite significant. And the diabetes management program, which is less intensive, leads many of the patients who choose that approach in the beginning to move on to our reversal program. We are, I think, like all of you, addressing the issue of the GLP-1 massive utilization in the United States, and these medications have enormously positive contributions to health, but they're incredibly expensive, and so we find that a lot of our clients and patients are interested in an alternative, and we've shown relatively similar results across a year of outcome research. We also find it's really important to show our clients that these results are possible in a diverse population, and so we see these results across ethnic groups and importantly across socioeconomic diversity. And as we try and treat everyone who can benefit from this sort of program, we find these results to be quite impactful. And I'll just finish up with an example to sort of show you on a single person level what it means. Kevin was spending $6,000 out of pocket for co-payments for his medications. He joined Verta, eliminated 3 medications, dropped his A1C by 1.1% and lost 50 pounds, and really sort of felt like he had taken control of his life and changed it dramatically. And it's stories like this that really sort of keep us motivated. So I'm delighted to explain this to you today.
Thanks, Adam. Charlie Summers is one of the founders of Grow Health in the UK, previously called diabetes.co.uk, and she's going to go through their programs as well. Thank you.
Good afternoon. My name's Charlie Summers. I am co-founder and Chief Operations Officer at DDM Health. Our mission at DDM is super simple. We know that someone's ethnicity, their postcode or location, and their household income directly impacts their chances of accessing services, whether they be digital or otherwise, and even more so of their chances of success and achieving those outcomes. And so our goals and aims is to really make weight management or metabolic health equitable. And one of the things that's been really important for us over the last 15 years of running our organisation and developing out these digital health tools is to ensure that we're driving the evidence base and supporting the understanding around how they can be implemented. I'm certainly only as strong and good as my amazing team around us. And so from a senior leadership team perspective, our tools have been developed by clinical experts around the world, certainly co-designed to a certain extent with the likes of Swiss Re. But my team that I work very closely with have a background in big data and AI. I've been working one of the foremost experts in cardiometabolic health, Dr. Amit Kaura, who's our Chief Medical Officer, and has been leading the cardiometabolic support that we deliver to our patients. You may also recognise Professor Grant Brinkworth. He's one of the foremost experts and leading researchers in nutritional therapy in Australia, and we've been lucky enough that he's been seconded to DDM to support our launch with our solution in Australia. We also work with Dr. Petra Hansen, and with her we've been really pushing the boundaries with how we can implement digital health services and virtual care services within hospital-based weight management teams, and how this can empower people as they go through the tiers of weight management, ensuring that they're supported in between those clinical visits. And Dr. Peter Foley, he is our clinical safety officer with a background in metabolic health and a specialist interest in digital transformation. So Grow Health, which is the big brother or sister to the low carb program, as Dr. David Unwin mentioned earlier, is really looking at supporting obesity and complex comorbidities resulting from obesity. It's a virtual weight management service, but also it utilises a number of different elements, such as a digital service. And going back to our mission and looking at supporting those different people as they go through the program, it's hugely important that we remove the inertias and the barriers to entry when it comes to getting access to these care platforms. And so you can see here that the platform itself is available in a number of different languages, not only translated into those languages, but really taking into account those cultural norms, the social expectations of the populations that we serve. And what we've been able to do is look at developing out the evidence base for supporting people irrespective of the health condition that they may come in with. A little bit of insight, so we started with nutrition only with the low carb program, but we know from a holistic approach when it comes to addressing type 2 diabetes or obesity and other cardiometabolic conditions, we have to address the whole human. So we have the elements and the modifiable risk factors that we take into account as we deliver our service, is looking at supporting people when it comes to their sleep hygiene, their physical activity, certainly their nutrition, and the low carb program sits as one of the nutritional options within the platform, but very much looking at someone's well-being and their psychological health as well as they go through the program. And what's really exciting about utilising digital services and this virtual care platform is that we can really tailor and personalise the individual journey that someone goes through as they go onto the program. It's been a journey for us at DDM, so the evolution of Grow Health, one of the things that's particularly exciting is that we've been able to be positively reviewed by NICE, the National Institute of Clinical Excellence, who have demonstrated and supported this as a proposition for implementing weight management services. So with the results that I'll come on to in a second, you'll see that we've been demonstrated to be as beneficial and as effective as face-to-face clinical services that you may get within a hospital weight management service. And now what we're able to do is deliver this with that NICE endorsement and the NHS approval as a medical device within those services. Some of those other things along the journey is that we are due to be launched in Australia in the not too distant future. We've done a lot of work in other territories, but with the help of Professor Grant Brinkworth, we're exploring and expanding into new and exciting places. We're supporting people, and we understand that it's a natural instinct to want to, in some cases, short circuit weight loss, and so a lot of people are taking up access to medications that they may not have previously had access to. We know it's hugely important, though, to support them with behavioural change as they are going along that path, so we'll be launching our medicated service. And then, again, implementing our service with the likes of devices that are supporting someone in helping sustain those behavioural changes and helping ensure that they're utilising their own data. Just a quick slide on the peer-reviewed outcomes that we're seeing. So you can see here there's a number of different studies, so 15 studies that we've published looking at the outcomes and the impact of the Grow Health solution in different populations. In patients with type 2 diabetes, we're supporting around a 7% body weight loss reduction and remission in at least 1 in 4. The low carb program outcomes are now at 7 years, and we're seeing sustainable improvements over the course of those years. And then we're also seeing the positive impact on other elements such as mental health, so looking at depression, stress, anxiety, and the positive impact that we're seeing there. And I'll just finish with a couple of real-world case studies. So you can see here just 3 people who have gone through some of our programs I think we're up to about 485,000 people who have gone through our low carb program to date. What's really exciting about a couple of these is Paul here. He was accessing the service in Bengali, and he was able to reverse his type 2 diabetes and put that into remission. And David, on the other side of the coin, he had and was living with type 2 diabetes for 23 years. And after 12 weeks of going through the low carb program, he was actually able to place that into remission and sustained that weight loss and the improvements that he's seen, which has transformed his life. Thank you.
Thanks, Charlie. So Emma Cole works in the Netherlands, and is going to be telling us about a program that in fact is covered now by health insurers in the Netherlands. Thanks, Emma.
So I'm Emma Coles, and as John just said, I'm the co-managing director of Voeding Leeft, a Dutch foundation. A Dutch foundation. I formerly worked for 7 years as the global head of health and sustainability for Ahold, an international supermarket group, where I was also the co-chair of the health group within the Consumer Goods Forum, which means I have more insight than I wish to have in why the international global food industry is not incentivized to help address public health. So I left. I've also worked in IT, and I love data. Voeding Leeft, we were founded in 2011, and we develop and implement lifestyle programs. And as you will have seen from all the discussions we've had today, there is a theme that runs through the programs that we develop, and that is metabolic health. But I'm here today to talk about our diabetes program. That's a 2-year program with a 6-month intensive phase. Our nutrition component focuses on many of the aspects that have been talked about today. We believe in nutrient-dense real food, and we've seen great results. Our first pilots were in 2014 with 10 people, and we'll be reaching our 5,000th participant this year. And as John said, from the 1st of January 2024, we'll be fully included in the Dutch health insurance system. Can be a double-edged sword, I can tell you. Thank you. So what we have all talked about today is that this is the solution, unfortunately, for the majority of people with diabetes around the world. And what we also know is that what happens is every year you get another pill. A couple of years, you get another pill. So I thought I'd have a look at our data from the almost 5,000 people that have applied for our program to see how long have they had diabetes and what medication are they using. So I see that the medication is just steadily going up over the years. And the patients at the far right, those are patients like Wim on 200, even 300 units of insulin. And maybe we could say, okay, that's okay, because it gets the blood sugar down. So maybe we've got a solution. Would be great. But that's not what we see. The blood sugar remains high. And the people on 200, 300 units of insulin, what we also see is we can cut that in half, and it has almost no impact on blood glucose. So something else is needed. A couple of examples of our patients, similar stories. Mario on the left, she did the program in 2016. She was using 102 units of insulin. She was able to stop, and she's currently on 500 grams of metformin. And one of the biggest impacts for her was that she felt she was old before her years. She's got her energy back. And Shagita on the right did the program in 2018. She was on metformin, and she was able to stop. We've also published our results after 6 months and 2 years in the British Medical Journal. We saw nearly 30% no longer using diabetes medication. The majority can stop insulin or SU derivatives. And most importantly for us, significant improvement in quality of life. And what we've seen is we've been able to keep these results stable through the years with a huge focus on the quality of the program and the team that supports our patients. We've got insurers in the room, so in comparison with insurance data, this is from one of our Dutch insurers. They put together a control group for nearly 40,000 patients, compared it with the patients, 554 of our patients, and looked at what's the change in medication claims. And the yellow is the scale of medication hasn't changed, so you're still on metformin, or if you're still on SU derivatives, or if you're still on insulin. And we saw that normally we see an increase in the medication within the group or going to a worse group, and very few people reduce. And the data from our program, more than half of the population reduced their medication, and many people, even in the yellow group, reduced the quantity of medication. We haven't published these results yet, but we are analyzing at the moment. We also have data 4 or 5 years from the group that started in 2017, so the same group that's in the BMJ publication, and we see sustained weight loss. And unsurprisingly is that the greatest weight loss happens for the patients that are on SU derivatives and insulin, because as we all know, we put someone with insulin resistance on a drug that increases their insulin, or we give them more insulin, and in the long run, we're making the situation worse. So what we say, we know that lifestyle works. The question is, what can we do to make it work? Thank you very much.
I don't know how many people in the audience or online are kind of thinking to themselves, what are we doing? Why is this not wholesale spread out around the world? It is astonishing, right, that it isn't. But very inspirational. Thank you all very, very much. So I think we've been given 15 minutes. Thank you, Andres. So we've got 15 minutes of Q&A. So please come up and please introduce yourselves. Thank you very much. Go for it, Dorian.
My name is Dorian Greenow. I'm the founder of Keto Mojo, and my question is for Dr. Wolfberg. Virta Health utilized ketone and glucose testing in what Dr. Hallberg wrote on a continuous remote care model versus an episodic care model. Can you give the reasoning behind testing both of those biomarkers?
So originally, Verta was focused on reversal of type 2 diabetes, and so as a comprehensive solution for the patient, monitoring their glucose was a key component of their diabetes management. As the therapy is dependent on creating ketosis for the patient, measuring ketones became a daily mechanism for patients to interact with their coach and understand their nutritional status. Obviously for our non-diabetic patients, daily glucose measurement isn't necessary and we don't do that. But measurement of ketones, particularly in the beginning of the program, has been very effective.
Thank you. Go ahead.
Thank you. I'm Stephanie Baldewig. I'm a professor of diabetes and endocrinology at University College London Hospitals. I've got a question about health inequality. Many of our patients where in the UK medication to them is free, not to the system, not to all of us, but to the patient is free, and food is expensive, have objections. They say this is very difficult for me to introduce a low-carb diet. And one of the slides very clearly showed in the States that the system applies to all patients really, so it should be useful. But I just wonder what your thoughts are on in all countries health inequality and how you would apply this.
Thank you very much. I'm just going to say one word and then I'll pass over to David, who I think deals with a lot of people who might be struggling. But so often we if you go and Google low carb diets, you will find pictures of salmon and avocado and macadamia nuts and fantastic olive oil, right? And it would be quite expensive. And so, David, in that context, what's your view on cost and food?
Yeah. It was interesting. We asked our patients with less money about this. And they said, after they'd been through what we did, they said, if you're honest and you look at your overall budget, not just for food, but also for junk food, if you look at that budget and include the Coca-Cola and the biscuits and the things you buy when you're getting fuel, the actual cost of low carb is about the same. So you do actually spend more on your food, but you're spending a lot less on the junk, is what we were told. What we've done in our practice, instead of the avocados and that in the north of England, we're thinking more about cheap things like eggs or even double cream. So we're looking for nutrient-dense, cheaper foods or mince. So each of us has to adapt it really for the local population, and that requires quite a lot of effort. But my patients say, if you include the junk, it doesn't have to cost more, but it does take some skill. One of the limits is cooking skills. So we actually do cookery lessons as well.
And if I may comment, there was a meta-analysis review looking at the extra costs for eating a more healthy, nutrient-dense diet, and it came out to be $1.71 per day per individual. So I agree, when you take the unhealthy out, you have a lot more room to put the healthy in.
Thank you.
Anyone else want to comment on that?
Just wanted to comment on the health inequalities, and I think one of the fundamental parts around and one of the inertias for getting those hard-to-reach populations involved in these kinds of services is making sure that it's accessible. So looking at technical literacy as one of the elements. Another one is making sure that the recommendations and suggestions that you're making for the food swaps are applicable to the cultural norms, their family environment, and all of those elements that really come into play that ultimately decides whether or not someone adopts these changes and that they're sustainable or not.
Thank you.
Thanks all for the inspirational talks. My name is Francesca Tam and I lead the behavior research function at Swiss Re. So this is going to be the topic of my question to the whole panel. And I was wondering, could you highlight some of the best practices to achieve this long adherence and the sustained results?
To achieve the sustainability, is that what your question was?
Yes, so I've seen some references to lasting impacts for 2 years, some even longer. What is it that makes that happen?
So as I alluded to when I spoke, it's really, I think, number one, helping that patient find their purpose, the reason why, and letting that be the driving force moving them forward. That leadership piece that I mentioned at the end, I have found that to be a key driver. When they're put in a position of accountability, further fostering those relational pieces, that's a significant driver. And then lastly, it's helping them become self-aware of the benefits they're making beyond the scale and even the glucose and the blood ketone or blood ketone levels. It's having that somatic awareness. I feel better when I am doing this. And if you can help them make all of those connections, that's when this becomes sustainable.
David, go ahead.
I think a key point is helping people learn from their mistakes. Everybody makes mistakes. Everybody loses weight and it's what you do, it's what you learn. So I'm really involved in, like, this Christmas has gone badly. What will you do different next Christmas? And it's about educating and empowering people over time to get wiser as they get older. And that really helps.
Yeah, and I think the education is key, David, that you also do. Explaining what's going on in your body really, really helps. And you can do that in a very, very simple way. Because if you understand the changes, you are more likely to make them. And then on top of that you measure, and the behaviour change component is key, really helping people understand why.
I would also say about being honest about the impact. So working in obesity clinics with very, very overweight individuals, being honest with them that their relationships with their significant others may change, their relationships with their family may change. Someone who wouldn't ordinarily be pointed out, "Are you sure you're going to eat that?" when it's junk food, then suddenly when you switch to eggs and double cream, there's the conversations around whether or not this is going to be healthy. So being honest around the impact on someone's broader environment and making sure that you're facilitating improvements and acknowledging that as well, I think is hugely important and quite often overlooked.
Thank you.
Thank you. Thank you very much. Just to note, Francesca, it's really interesting too. So I've been kind of involved with many of these people and in the topic for many, many years. And when the first study started coming out, it was 6 months, and everyone said, "Oh, well, it's not sustainable, right? That's just 6 months." And then we got 1 year data, and everyone went, "Oh, it's only 1 year," and then 2 year data. And it's really interesting, right? It's kind of this constant belief that, hang on, this is not sustainable. But, a lot of people have been doing this for 10 years now. But of course, behavior change is hard, and food is addictive, so it's tough. Thank you.
Hello, my name is Adriel Camilleri. I'm a medical student from Malta, and I'm currently serving as the president of the Malta Medical Students Association. So my question is kind of general to the panel. With the ever-growing popularity of GLP-1 agonists, such as Ozempic, are there any points in particular you would make to patients to kind of convince them that there's no such thing as a one miracle drug, and that at the end of the day, lifestyle changes are going to be a better long-term fix compared to these types of medications?
Anyone want to have a go?
You go ahead.
Go for it, Adam.
I think that that's a really hard message right now because these medications have taken over the popular imagination. I think that we're also seeing the beginning of some evidence that they might not be the panacea that we all think they are, both in terms of sustainability, lean mass loss, side effects. And I think that this is a conversation that's going to play out over the next several years. And as people see these remarkable results and want to sustain them in a different way or can't sustain them with the GLP-1s, and I think alternatives are going to become even more important.
David?
Yeah, so I'm an old doctor talking to a young doctor. You know, in my long career, I think I'm on now about the 5th or 6th miracle drug for obesity. So, you know, maybe it's going to, I hope it turns out well. But, you know, in the past we've had valvular heart disease. We had another one that was causing people to kill themselves. Miracle drug after miracle drug does not manage long-term results, and that's what worries me. And also, we have I'm reluctant to experiment on my patients. We have no idea what will happen over 20 years with this. And my third point is, how do these drugs in any way address the actual cause of the problem? And until we address the cause of the problem, it's not likely that we're going to have success. Thank you.
Thank you very much. I'll add one more quick thing. I'm a very strong believer in patient choice. And so I think it should be patient's choice, right? But it needs to be informed. And at the moment, it's very hard to inform people around these medications because we just don't have the long-term data, right?
But I will say in my clinical practice, because I do prescribe them, patients come to me, and one, I utilize them for diabetics with the goal of always getting rid of them. But I do have patients, especially those, you know, with food addictions, that it is a tool, like many, but unless it's accompanied by something that is creating behavior change, it's not going to have that long-term success. I've also seen, just in the short term of utilizing it in my practice, a lot of side effects. Patients are not tolerating them. I've had a patient develop significant persistent gastroparesis even after discontinuation of the medication, and it does create a ceiling of benefit. Patients think, I go on this and I'm going to get to my goal weight of 120 pounds of what I was in my high school years. That's not the reality. Even this does not get people to where they want to go. And then that becomes frustrating and they give up on that as well.
I think also it's very important. We know that lifestyle works, but how is our living environment? We are living in an environment with 80% of the products in the supermarket are unhealthy. We have a marketing budget of Max Verstappen for Red Bull, who is higher as all the vegetable budgets in the world. So we need to do something governmental about changing our environment, that the healthy choice is the normal choice. And as long as we don't do that, we know, and that only the strong people, they will survive, but it's so difficult. You have to beat, every coach has to beat Unilever.
Yep. Thank you, Wim.
My name is Christoph Nabels. I'm the Chief Research and Sustainability Officer of Swiss Re. First of all, big thanks to the whole group here. You're making a difference. And my specific question here goes to actually Charlie. You managed to crack the code, the data code, with NICE actually approving you. Can you give us a bit of some insights? Because I think that's what we're striving for, to get the data to actually convince the regulators to take the action and the proof. Because only this way we can actually change. So, Charlie.
Yeah, absolutely. So we've been through an extensive review process with NICE, and so this is the UK-based Clinical Excellence Board, and they were reviewing, I think there was something like 400 different platforms or studies that they were looking at, and in particular different propositions that were both alongside or could be used alongside medication for weight loss and also in their own rights individually and on their own. So we're now one of 6 organisations in the UK that's been approved for use and positively reviewed by NICE. And what was clear from a lot of the consultation processes was that there was a number of things that they were looking at. One is the cost efficiency of these services. One is the sustainability of the impact that we were able to see. Another one is the application and how easily it is to be embedded within clinical services. And essentially of this very, very long, horrible process that we've gone through, and to be one of 6 services now available in the UK. I think a lot of the world's healthcare systems utilise the UK as almost the test bed for some of these elements. So yeah, it's been I wouldn't say it's been an easy journey at all.
Big congratulations.
Thank you.
Yeah. I think it's a lot easier to get Ozempic approved.
Yes.
It's true. Okay, we've got 5 seconds, Nicole.
Oh, can you please publish or put me towards the multidisciplinary piece or the multicultural piece, because that's really important in mental health and in integrating that. The way that you do low carb for different cultures.
Yeah, no worries.
Thanks, Nicole. David, last question.
A brief comment on the GLP-1 issue. I think we should consider this basically proof of concept of a low-carb diet. Traditionally, people think of these drugs as raising insulin because of isolated test tube effects. But that's actually not what happens in clinical trials. The effect on slowing gastric emptying is dominant. So you can see that with initial GLP-1 treatment, insulin levels go down, gastric emptying goes down, nutrient absorption is decreased, ghrelin goes down, and adiponectin goes up. All of these things happen immediately and are persistent, even though there's some tachyphylaxis. What does that sound like? Well, that's exactly what a low-carb diet does. One of the arguments for a low-carb diet is that it slows nutrient absorption, lowers insulin, and creates a better match between our metabolism and nutrient influx. So my question to Adam, will you fund a clinical trial looking at a GLP-1 agonist together with a low-carb diet for synergy? That's sort of tongue-in-cheek.
Sure. So Verta's a startup, late-stage startup, and so from a research perspective, we can't begin to compete with the pharmaceutical companies, but we would be delighted to participate in either a combination study or a head-to-head study. We would be thrilled. If anyone wants to do that, please come find me.
Interesting that in the Netherlands, if you don't have diabetes and you want a GLP-1, you have to join a 12-month lifestyle program first. Now, whether you join that with much energy or not is yet to be seen, but we all know that the results are far better if you combine the GLP-1s with lifestyle. So it will be an interesting test to see what happens in the Netherlands in coming months and years.
Thank you, panel, very much.